Hi, and welcome to the Restorative Wellness Clinicians Corner, a video series exclusively for functional health professionals, where we interview the top experts in the latest research, products, tools, and best practices for getting your clients exceptional results. Hi, everybody. Welcome to today's episode of the Restorative Wellness Solutions Clinicians Corner. I am your host, Margaret Floyd Berry, and today we have another Clinical Pearls episode for you. This one is from our chat with Dr. Nasha Winters on a totally different approach to cancer. Rather than attacking the cancer itself, we learn how to create an environment in the body that's inhospitable to the proliferation of cancer cells. It's one of our most popular episodes, and we've extracted some of our favorite clinical pearls to share with you today. This interview first aired back in 2023, and the full interview can be found on YouTube or here on the Clinicians Corner podcast as episode 2. For today, we've pulled out some of our favorite components of the conversation for you, so consider this a teaser. Enjoy.
And so for me, this wasn't a vocation. It didn't wake up one day and say, gosh, I think I'm going to really focus and specialize in cancer. Like many of you, I had my own dance with this process at a very ripe age of 19, actually. So 32 years ago, this coming October of 2023, I was given a terminal diagnosis. Standard of care had missed my process many times over, unfortunately. And by the time I landed in the hospital, really down the rabbit hole, they did not have anything to offer me. And so I had no expectation of surviving this. I just wanted to understand why a 19-year-old would have a diagnosis of stage 4 ovarian cancer that everyone seemingly missed for a very long time. And so that has been a 30 plus year journey for me to understand my why, but then also to apply that to, at this point, over 10,000 patients directly and likely hundreds of thousands of patients indirectly through my work of trying to understand why we have this cancer process going on, which I know is what we're going to speak a lot to today. Some of the ideas around what this may be. But one thing I want to mention is that just a few short years ago, a decade or so ago, when I would present at a medical conference, I would literally ask the question, how many of you in this room have had a personal experience with cancer, whether your own diagnosis or someone near and dear to you? And at that time, maybe 20-30% of the room would raise their hand. I have to reframe that question today. Now I have to ask the question, how many of you have not had a personal experience with cancer or someone near and dear to you? And now maybe a handful of hands go up. That's what's happened in a very short period of time. And unfortunately, despite the fact that the RWS community does not focus in oncology, you will see more and more of this in your careers. And we want you to feel empowered and supported to be able to meet those folks and bring the support that's much needed in this growing global community.
So how does the work that you do differ from alternative healthcare, cancer treatments in general? Like, what unique approaches or perspectives are you bringing to the table?
Sure. Well, one thing is, I will tell you from the early days of my diagnosis, I was pretty, disgruntled might be a good way to describe of standard of care, of conventional medicine in the very beginning, because I had been missed. I was in that time in my diagnosis, I was very much a victim. I was very angry at the medical establishment. I was sort of angry at the world around me of how this could have happened. But my tune has changed over these last decades. And what I realized is when I sort of objectified standard of care as the problem, that wasn't helpful. That wasn't helpful for me or for anybody else on this journey. Just like over time, when I started to meet more and more people that were really frustrated with standard of care, I was the weird voice out there asking for them to consider that there are options to do the best of both worlds, to upgrade standard of care as we know it, and to really use data to understand what alternative therapies or integrative therapies are best for each of us at whatever given time. And so that sounds maybe a little cryptic right now, but ultimately what I've learned over my 30 plus years is there's the best of both worlds. There is a thoughtful methodology in choosing the right treatment at the right dose, at the right duration, at the right combination, at the right time. And that may or may not include things from standard of care, surgery, radiation, targeted therapies, immune therapies, et cetera, but also may include what are considered alternative therapies. I like to talk about them more as integrative, because alternative, for whatever reason, has sort of a bad taste in a lot of people's mouths. And it's even funny that over decades, we've changed the definition. It used to be the alternative medicine kind of group out of NIH, was this very small group that started back in the early 1990s. Later, it became known as CAM, Complementary and Alternative Medicine. And about a decade after that, we changed that terminology yet again to CIM, C-I-M, Complementary and Integrative Medicine. So even in the last 3 decades, even standard of care has renamed who we are. And when I think about alternative versus standard of care, they tend to still be at both sides of an equation. And there tends to be this huge chasm in between. And what I've aimed to do, and what I hope you all walk away with from this conversation today, is there's this beautiful bridge that can be built between the two. And that there is a particular methodology and way of thinking about when is the right approach for you or a loved one or a client at any given time. You don't have to guess of when that might be. And you certainly don't have to depend on just alternative or just standard of care. I believe they should both be offered simultaneously and in the right circumstances and the right combinations. And so what I've learned over 3+ decades is that there are kind of some common denominators of what might contribute to a cancering environment or a cancering terrain. You'll hear me use that word a lot. Katrina has already alluded to these terrain drivers. And so you look at some of my colleagues like Paul Anderson, he talks about maybe the 7 of these things, or Dr. Jimenez talks about these. There's a lot of different kind of pillars or different drivers, contributors to health or disease. And for me, I've sort of categorized them into 10. So the 10 are as following, and I'm going to kind of blaze through this. So I'm glad you're recording, because I sound like an auctioneer sometimes. So number 1 are epigenetics. This is the blueprint we were all born with. Okay. This is not your destiny. This is above the genes, that you have the ability to make dietary and lifestyle choices that change the expression or suppression of a whole pile of genes that you came into this world with. And that could have been influenced by 12 generations upstream from you. That's what's so amazing about the research. But it also means that you have the opportunity to change 12 generations downstream from you with choices you make today. So a much more hopeful and empowering message than what we're often taught to believe, that our genes, pull the trigger. We're not sitting ducks. We're not victims. We have a lot more opportunity to change expression than we're led to believe. Number 2, our metabolic machinery. Now, we're going to talk a little bit more about this here in a moment, but ultimately, what fuel are your cells using to drive this container, this meat suit down the road? Okay. And so we have a lot of opportunities to change the expression with that as well. Number 3, toxins. My teacher, the late and great Dr. Walter Crinnion in the environmental medicine world, he talks about the fact that we are no longer about if you have toxicity, it's how bad is it and how does it intermingle with the fuel you put into your body, as well as the epigenetic blueprint that you were born with. Because we all have a little bit of a different sort of kind of threshold, I suppose. Like my husband loves the smell of diesel, but I smell it and I immediately want to throw up and get a headache and or feel terrible. We all have kind of different thresholds, and that toxic exposure expresses itself differently. Number 4 are our microbiome. I mean, my gosh, as a naturopathic doctor who's been preaching about the microbiome my entire career, as well as has anybody from the Chinese medicine or the Ayurvedic medicine or the naturopathic medicine world, it's only been in the last few years that standard of care has caught up to the importance of our microbiome. And so basically what little critters are inhabiting in our body, living inside our bodies, that are helping us respond to our environment in a very different way. And so good or bad. And so we have the ability to adjust that. Number 5, our immune drop in the bucket. So if you've been living under a rock for the last 3 years, you might have missed that we've been in this kind of global pandemic. which to me, the real pandemic that Katrina alluded to is more about the chronic illnesses that are affecting us today. And we'll go into that more in a moment. But this virus should show us our weakness, our vulnerability with regards to our immune function or dysfunction or lack of function altogether. So that's a big contributor. And then we have inflammation. We're known as the inflammation nation now in this modern times. We used to die from infections. Actually, still did in the last couple of years. Shouldn't have though, but did. But we now die more from inflammatory processes. And so we'll talk about that. And then this angiogenesis, this oxygenation and circulation drop in the bucket. How well are you utilizing your oxygen stores? How well are you perfusing or bringing oxygen into your tissues and into your cells? Then number 7 is your hormonal health and the balance, the modulation of those. How does your body interpret your own endogenous hormones, as well as how does your body interpret exogenous hormones? And then the final 2 are the biggies. So the stress and circadian rhythm. So how is your body dealing with the day-to-day of, light and dark cycles, exposures to screens, hence the blue blockers, standing on grounding mats like I'm doing right now, things like that. Like, how is your body responding to sort of the stressors on your circadian rhythm today, as well as the emotional, the physical, and the energetic, and even environmental stressors that we're all exposed to. And then last but not least, the biggest drop in the bucket, often the least dealt with, because it's always easier to deal with the tangible, is the intangible of the mental, emotional, spiritual sphere of things. And even one of my teachers, friends, colleagues, Dr. Kelly Turner, who wrote the book Radical Remission, she talks about the 10 major factors of radical remission or spontaneous remission individuals. And only 2 of those are tangible, maybe 3, but one of them, diet. You do have control over that. That's something you can do. Supplements. Okay. So that's another thing you can do. She later brought in the category of exercise. So thank God we got Katrina here, who's really big on this topic, a published author about this topic. But all of the other 7 drivers, 7 factors, all are on that mental, emotional, spiritual, and stress response environment. And that is the one thing that's most difficult for most of us to achieve and remain healthy within that context. So I told you it would be fast and furious, but those are the big 10 drops in the bucket, the terrain bucket, that impact our health or disease state at any given time.
Okay, so let's dive into the food. We are primarily a lot of nutritionists. So I know everyone wants to know, can you talk about the big elephant in the room? What does diet, how does it play into cancer? And what are your thoughts on that?
I love it. Boy, howdy. Talk about dogma versus data, right? This one is a big deal. This one, because we have to remember that food, I'm preaching to the choir here, so apologies for that, but food is very emotional, right? Everything we do is celebrating around food. It's a reward system. It is impacting even our neurochemistry. So all of these different things literally drive our very behaviors and our relationships and our patterns and our lifestyle choices. So with that being said, is there one single diet for the planet? And there's no easy answer, and there's no one diet. But there is the way to assess what diet in what moment fits that person's epigenetics, fits their labs, fits the goal of whatever treatment outcome or outcome for the patient we're striving to meet. But I think there's a few simple kind of common denominators. So whether you're in the carnivore camp or the vegan camp or the paleo camp or the keto camp or the omnivore camp or the breatharian camp, maybe not the breatharian camp, but ultimately across the board, we need to be thinking today, living on the planet, of the major changes that have happened in the last 150, 200 years or so, is that we are incredibly metabolically broken. And by that, I'm pretty sure in this room, everyone would agree with that. I even see a few emphatic head nods. And so specifically when I say that, and why this is important to preface the conversation around diet, is in 2018, there was that Chapel Hill, North Carolina study that came out showing that less than 12% of Americans And can we just yes, we're being American centric here, but really this is true for any really westernized developed country. It's not America centric. Like the rest of the world is quickly on our heels, if not even a little bit ahead of us in our metabolic brokenness. But ultimately, let's just say, for sake of argument, that 12% of the planet, of adults on this planet, are metabolically healthy. So that already is telling us that 88% of us aren't. So common denominator there. But then we fast forward post-COVID in July of 2022, the cardiology community came up with an updated number to this. And I'm sure you guys have talked about this ad nauseum, but we now know that less than 6.7% of adults on the planet are metabolically healthy. What this should land on all of you is to realize you have, unfortunately, major job security. Okay. We don't want that, but it's the reality, and we need you because we have a large population now at this point. Close to 93% of adults on this planet are in trouble metabolically. By that, I mean that they have problems with their blood pressure, problems with their blood sugar, problems with their lipid profile, problems with their hip to waist ratio, problems with their stamina, problems with their musculature and their the strength of their muscles and the function of their muscles. So with that being said, all of those things, if you have to take a medication for any one of those things, you fit into the classification that you're metabolically broken. So if you're like, well, my blood pressure is perfect, but you take 2 different pharmaceuticals to make that happen, that is not perfect, right? If your lipids are off kilter and you take a pharmaceutical for that, that is not perfect. I also want to qualify that even what these 2 major studies described as being metabolically healthy, we still in our community, in the Metabolic Train Institute of Health community, as well as likely in the RWS community, we have a bit tighter patterns of what we think is healthy versus not healthy. And so to qualify this a little bit, and then I promise I'll get to diet, but labs today are based on the average of the population in the region in which they're being run. So how many of you here have seen like labs from patients getting their labs drawn, say in the state of Colorado versus labs drawn in, say, the state of Kentucky or Alabama? When you put those labs next to each other, right? Especially because you look then at the demographics and you see who has the better health outcomes. Colorado is up at the top 3 typically every few years when that gets redone. And unfortunately, Alabama or Kentucky are usually at the bottom 3 every few years. So when you look at when they say, hey, in Alabama, your blood sugar is fine if you're at 120, a fasting blood sugar of 120, right? In Colorado, they say it's a problem if it's over 90. Do you see the difference? That's a problem. So we want to base our labs and our evaluations on optimal averages, not based on the averages of the population, especially now that you all realize that 93% or better of us are metabolically broken. So you don't want to fit that average, right? So for instance, a blood sugar, when they say, oh, your blood sugar should be under 100 for you to fit in metabolically healthy, my suspicion is we're actually not even 6.8% of us being metabolically healthy, because most of the labs I look at, it's very, very rare for me to find a blood sugar under 85. And yet that's my range of a healthy fasting glucose level. The other thing is a fasting glucose level really means nothing, right? It's so transient. It's so dynamic. It could have been a stress response or a dawn effect. It could have been what you ate or didn't eat in the days leading up to this. So what's more telling is an insulin, a C-peptide, or hemoglobin A1C. Those are going to give you less fudgeable results. And that is where in our crazy medical system, we don't even run those tests unless someone's glucose gets too elevated, quote unquote, under that 120 zone. So you can imagine the numbers of people we're missing that are falling through the cracks that are metabolically broken. So the same thing kind of comes down to the blood pressure. We are super, super obsessed about a blood pressure being 120/80. Anything above that, we consider that being a problem. But here's what's really weird is we also overshoot our treatment of blood pressure with pharmaceuticals. And we make these people with like blood pressures of 90/60, like almost ready to pass out, who have no oxygen in their system, setting them up for a cancering process, because a hypoxic, low oxygen environment is one of the biggest triggers to set off growth factors for the cancer world. So you don't want to be over-treated there. Similar in the lipid world. So we've been terrifying. So when I was in medical school back in the 90s, before statins hit the market in 1996, was anybody else practicing or looking at labs prior to 1996? Probably a lot of you weren't even born then. So, you're welcome. This just made you feel better about yourself. But in 1995, 1996, the cutoff for overall cholesterol was 399. The cutoff for overall triglycerides was 399. The cutoff for overall LDL was 299. We didn't know anything about HDL. We didn't know anything about very low VLDLs or any of those things. We didn't even have that nomenclature at that time. We only started to lower the parameters of our lipids based on a pharmaceutical sale, not on the reality of a patient's outcome. So let me rephrase that. The advent of statins coming out on the market in 1996 has had virtually no effect on overall survival rate from cardiovascular events to the human population. And yet every few years we try to push that number lower and lower, 399 to 350, 350 to 300, 300 to 275, to 250, to 200. I feel like an auctioneer. Do I get a 200? Do I get a 175? We're now pushing for patients to get their blood pressure, their overall cholesterol levels under 175. But in the oncology world, one of the most ominous signs I will ever see with a patient when I'm reviewing their labs is a low cholesterol. Anything under 175, I start to get a little chill up my spine. If it's under 165, I'm looking for cancer. Let that sink in a little bit. So we are pushing people in the wrong directions, and we're not talking about what really matters. We also spent the last 50 years in this crazy experiment saying that fat is bad and sugar is good, because we said fat's so bad, let's take it out of everything. But then it tastes so terrible, we have to bring something else on board. And so we do that by adding in sugar. And we've turned ourselves into sugar burners, and our bodies have forgotten to be this natural hybrid system that we were designed to be. I mean, do you realize we're all born in ketosis? Unless your mother is pre-diabetic, if you're gestational diabetes. But ultimately, non-gestational diabetes moms, their kiddos are born in ketosis, and they go into deeper ketosis before the milk fully engages, before the milk fully comes in. And so our bodies have this natural tendency. We're not meant to graze 24/7 every day of the year, every season of the year. You're not meant to eat a papaya in Durango, Colorado in the winter. You're probably not supposed to eat a pumpkin in, Mexico in the summer. Like, these are the crazy places that we've changed our world so drastically that we're no longer matching our genes, our season, our locale. We've gotten so far from that. So when we come back full circle to the dietary discussion, the main thing is to look at those parameters of metabolic health. Test, assess, address, don't guess. The other thing is you can no longer look at someone and tell if they're metabolically broken, because there are a ton of people walking around known as TOFIs. How many of you know what I mean when I say TOFI? Anyone want to shout it out?
Yeah.
Besides Katrina? I'd love to hear her.
Outside, thin outside, fat inside. Yeah.
Exactly. Thin on the outside, fat on the inside. And crazily, those are the patients that are more concerning than those who look the part of metabolic inflexibility. So this is the other piece here, is you can't know those skinny on the outside people are struggling just as much metabolically internally without testing. And a lot of times these folks have so much more visceral fat than their outwardly pudgy colleagues, that they're missed and they're more metabolically broken. And so these are where the testing comes in. But ultimately, this is where we can get into the fights about whether carnivore is better, keto is better, vegans better, vegetarians better, omnivore better, whatever it is. We don't have to have those conversations anymore. We go down to assessing the patient's metabolic blueprint based on those parameters we've talked about, the labs. So for instance, the insulin should be well under 5 in a healthy individual. Cancering should probably be a little bit lower depending on the situation. Just as some examples, there's this concept known as the GKI, which is the glucose to ketone index. The standard American is walking around with a GKI of around 25 to 30. To give you an example of how we use food or lack thereof, or a particular therapeutic diet to treat cancer, we aim to get that number under 1. Ketosis is a physiologic state. So let's start with that conversation. And there's multiple roads to Rome to get to that state. So you can get into ketosis with a high fat, low carbohydrate diet. That's one strategy to get you there. And again, let's talk quality fats, and let's talk not dirty keto or internet keto. Let's talk, and not high protein keto. This is not an Atkins diet. This is not even an Atkins modified diet. This is a clean, still veggie dense diet. So when I speak to this in my cancering community, I talk about the fact they still need 9 to 15 servings of vegetables a day. That flips people out. Now you can do that in this world. We do that a lot through pestos, and special sauces and soups and purees. That's actually a very easy way to get in that many veggies without blowing all of your macros out, into high carbohydrate land. And so if you stay basically above the ground, we don't even count the herbs and the leafy greens and radishes and cucumbers and zucchinis. We don't really even count those as our carbs, because those they're mostly water, they're high in fiber, and you just don't worry about counting those. So that's one place here. The other way to get into a state of physiologic ketosis is with actually eating nothing at all. So fasting. An intermittent fasted state. Our oldest strategy that we've co-evolved with since the beginning of time. We've used this as spiritual rites of passage. We've used this in healing, natural healing processes in ancient, Hippocrates times and beyond. This has been a strategy in pretty much every medical system known to humankind. Even in standard of care today, up until the 1960s, when somebody got it up there, a bee in their bonnet, thinking this was a really terrible thing to have patients do. So really, up until the 1960s, fasting was still a recommended therapy for many of our patients, even from the allopathic medical world. So when you fast, if you go 4 hours without food, you already start to move into a fasted state. By the time you hit, it's like 12 hours, 18 hours, 24 hours, you start to drop your glycogen stores. After that, you start to drop your insulin. And by day 3 of a water fast, you should be in a pretty robust state of ketosis. And this may need to guide people a little more elegantly. Again, please do the N of 1 on this, but that's one way to get there. Another way to get into ketosis is just carbohydrate restriction. Not even changing when you're eating or what you're eating, just less of the carbs without even having to go into the high fat. You can even get into ketosis as a carnivore if you have the right genes, and you can even get into ketosis as a carb restricting vegan if you have the right genes. You can also get there with exogenous ketones supplements. So ketone esters, ketone salts. These are some other means, and there's even pharmaceutical means to get yourself into a little low grade. Not very much fun to take some of those because they have other side effects, but you can take some of the exogenous ketones. So I mention that because a lot of people kind of get it in their head, and the confusion gets out there of like, well, I read something that fats cause cancer or drive cancer. Well, even when you talk to the experts in the metabolic field of oncology, that's an endogenous fatty acid synthesis or fatty acid oxidation process. And it's not based on the fat you're taking in, unless you're taking in terrible trans fats, high seed oil fats, high omega-6 fats. Those are bad for all of us, cancer or not. Those are the drivers of all of this, right? We just, a couple, generations ago, we were a 3-to-1 ratio anywhere of the 3-to-1 ratio of omega-6s to omega-3s. And 100 years prior to that, we were a 1-to-1 ratio of those. We're now about a 36-to-1 ratio of omega-6 to omega-3s in a very short window of time. And our bodies have not evolved with that. And so it doesn't know what to do with this information. So one of the conversations, this kind of brings Joe back into the conversation, Dr. Mercola, is he's talking about the importance of restricting linoleic acid. And when you really look at the linoleic acid, he's still like telling the truth on one level, but he's taking it to that extreme. The linoleic acid is what's so high in our omega-6 seed oils and the majority of the fats we're feeding our planet today. So I live down in Mexico and I can barely eat out. I have to ask for them to, I have to take my own oil or have them grill everything because everything is bathed in corn oil here. And I get a terrible reaction to that now. When I'm in Europe, I have to ask for them to use butter or olive oil because everyone's using canola oil or soybean oil today. So this is the place where we are all taking in just mountains of these oils and these fats. And so when we talk about specific to a cancer treatment, therapeutic ketosis state, we want to lower our inflammation by lowering our omega-6s. We want to carbohydrate restrict so that we can lower our insulin, which in turn lowers our insulin growth factor, which is the driver in, depending on the research, 70 to 90% of all cancer types out there. Okay, very simply put. So we don't have to get into the how, right? We just know that that's what you have to do. And so if you have patients that come to you that are very, very strongly committed to a particular dietary intervention, test, assess, address, don't guess. Look at their SNPs if they're not reaching or achieving a state of therapeutic ketosis or nutritional ketosis. Nutritional ketosis on your blood levels would be anywhere from 0.8 to 2, and a therapeutic level would be 2 and above. Right. And so when we're looking at that GKI, you want to get your glucose down as far as you can and your ketones up as high as you can to optimize this. And that's why things like time restricted eating, carbohydrate restriction, intermittent fasting, extended water fast, these are ways that you can keep pushing your body into that healthier GKI to push your body back into that beautiful dual hybrid engine that it was designed to be.
Hey practitioners, can we have an honest chat about fertility cases for a minute? When a client walks in and says they're trying to conceive, do you feel confident or a little unsure about what to do next? Let's be real. Even with advanced training and clinical tools, fertility cases can be some of the toughest ones that you'll face. There is so much going on beneath the surface, and when your clients aren't getting the results they want, it's hard not to wonder if you're missing something. Here at Restorative Wellness Solutions, we want to make sure you feel 100% confident and well-equipped to help every single fertility case that walks through your door. That's why we're inviting you to join us for a free 3-part live fertility masterclass series where we'll walk you through how to tackle even the most complex cases step by step. We're covering everything from laying solid nutritional foundations to figuring out which tests to run to using simple sex-specific tools that help your clients get better results. Whether you're brand new to fertility or you're looking to go deeper, this series will give you a practical clinical framework that you can start putting into practice right away. So don't wait. Head to the show notes, click the link for Precision Nutrition for Fertility, and grab your free spot now. You and your clients will be so grateful that you did.
Okay, so we have one more question. There's a question talking about ketosis feeding cancer. Mm-hmm. Can you give us your thoughts on that?
Sure. So this actually comes up a lot. And first of all, there's a couple points to this. So first, when you take a look at these studies, go back and read the actual study design. What you will realize is almost all the studies that say this are not only not a ketogenic diet. Okay. Like when they sit there and say, we're giving the patient, this many calories of fat, and you're like, wow, okay, that's a good high fat diet, but then you're not really lowering the carbohydrate intake. Let me be very clear. When you give high fat, no matter the quality of the fat, along with high carbohydrate, that's a bad idea for anybody. Okay. If you give high quality fat with carbohydrate restriction, that can be a pretty good idea for most people. If you just give a normal high quality fat diet with a carbohydrate restriction, you're also getting people into a better state of health. So first of all, those studies are very, very skewed. They're not accurate. And when you look at first of all, they're usually in either cell lines, which mean nothing. If you don't have a liver attached to the study, you're not actually measuring ketosis. Okay, so that's a big one. So when you're like, oh, this is a cell line study that talks that acetyl, acetone could cause problems here. If you're not having a liver attached to that, be it an animal or a human being or a dog or whatever, you're not getting an accurate read. That's impossible. You need to have a liver in the process to really measure this. Number two, take a look at the chow that's being fed to the animals in these studies. First of all, it's all omega-6s. It's all high in linoleic acid. It's all seed oils, soybean oils. You look at these, they're the worst. Like, you would never feed another human being this type of a diet. So that is a bad idea for anybody. And the reason why, it's not that the ketones cause the cancer, it's the inflammatory process that's driving the cancer cells. And so they're blaming the ketones for what the inflammation is actually doing. And so these studies are really terrible. So when you get the experts like Dr. Thomas Daraj, Dr. Ahmed El-Saka, Dr. Thomas Seyfried, Drs. D'Agostino and Angela Poff, you bring these guys into the equation and they tear these studies apart left and right because they're not quality studies. They would never get published. And we don't understand how they even get in publication. But there's literally no studies where ketones directly drive or cause a cancering process. Ketone bodies don't have that ability.
Awesome. Thank you for clarifying. She asked, she's specifically asking about the BRAF mutation making it able to feed the ketone bodies and such.
And I remember when that BRAF 7600 study came out several years ago. It's one in a sea of other studies. So just to give qualification, I've been treating melanoma patients, which are typically BRAF positive and BRAF 7600 positive patients for decades prior to that study ever coming out, and never saw issues. There's actually been multiple studies coming out debunking that particular study. And again, going down and breaking down what I just described was the quality or lack thereof of the study. In fact, one of the cool things about ketone bodies themselves, they actually help reverse the mutation of a BRAF mutation. So there's some really cool things. We also know that ketone bodies have an impact on KRAS mutations, our natural PDL and PD-1 inhibitors. So there's a lot of really cool studies coming out that are actually becoming better quality studies because people are starting to take a look at the dietary formulation in these studies. They're starting to pay more attention to, and they're starting to do more human trials. In fact, I believe we're up to 62 as last time I checked on clinicaltrials.gov. I think we're up to 62 human clinical trials on the use of therapeutic ketosis in the cancering environment. So in a cancer patient, not in, these aren't animal or cell line studies. So we are definitely finally doing some more meaningful studies in this arena.
So there's some questions about, does this process work for children, and would you recommend a low carb diet for kids?
So actually, we learned about a therapeutic ketogenic diet over 100 years ago in the pediatric epilepsy community, a study done through Johns Hopkins, and has been utilized for over 100 straight years in the pediatric population ever since. And as I mentioned before, we're naturally born in a state of ketosis. So it is a natural state of our being, and it's something that is safe to drive people into deeper. And so in my world, I have a few experts in our network that are pediatric focused. I have colleagues who practice in hospitals and institutions all over the world who focus in pediatric oncology. And metabolic flexibility and metabolic ketosis is just as critical and supportive in that environment as it is in the adult environment. And there's no safety concerns or differences in the way we approach it in either in either age group. So I think that's pretty exciting. There's actually a book coming out in early 2024 by one of our graduates and one of our colleagues, Dr. Dagmara Bain. This is her jam. This is her area of expertise. And being the mother of a daughter who's gone through this process and is doing really, really, really well, one of the things we know specifically, like childhood cancers, are often things like sarcomas, leukemias, lymphomas. These, ironically, are some of the most highly glycolytic, highly metabolic cancers out there. And also the brain tumors, the neuroblastomas, the medulloblastomas, the DIPGs, the astrocytomas, also giant glucose hogs. And so this population are the easiest to work with. And especially the younger they are, the easier. The hardest part of working with the pediatric population is just their parents, as you can well imagine, because it's the parent going through their own psychology of, oh, I'm going to keep my baby from having a cupcake. So it's about normalizing and knowing. In fact, I learned a lot that Katrina's family has become like the keto baking experts, and doing these things. Like, kids are really malleable and really easy to change. And you can make a lot of their fun special treats for them so they still feel normalized in whatever social environments they're in. But ultimately, your kiddo going through a cancering process and getting them on a therapeutic ketogenic diet, the whole family would benefit going on this. And so people like the Max Love Project, if you want to maybe give a link to them, Katrina, they're a family, an entire organization that focuses on pediatric brain tumors. And for using therapeutic ketogenic diet, you could look into the Arizona Children's Hospital studies in DIPG. We actually are getting a grant right now to do a ketogenic study in DIPG patients. Just so you know, this is a very aggressive brainstem tumor that has a 9-month survival rate with standard of care. And our only focus is to show that we can create better quality of life for these patients and their families. But we already know, because of our own clinical experience, that our outcomes are far exceeding than what standard of care can meet. I've got 3 or 4 patients over 10 years with the DIPG. That's never, ever heard of. And so these are the types of things that we can definitely be instrumental in helping support our pediatric oncology population in a tremendous way, especially knowing how safe it's been used in the epileptic community for over 100 years.
So thank you so much, Dr. Nasha. And you guys, where can they find you if they didn't get it already?
Yeah, please come look for me. Probably the best place right now, because it seems to bring everything together, is at mtih.org, which talks about all the things we're doing with our events and our conferences and where we're speaking, updated podcasts, other things along those lines are all, again, free resources, typically, as well as getting access to the newsletter, finding out about our trainings that are coming up. If you've got a doctor that you work with that you want them to get into the training, send them our way. But that kind of covers the gamut of all the things that we're up to, as well as our beautiful directory where Katrina is featured, Dr. Duhan is featured, Dr. Chris Smith isn't featured there anymore, even though he's come through my training program. He's like, I got enough going on. He wanted to come through our training program as the head neurosurgeon at Barrows Neurology in Arizona. He wanted to understand, because his outcomes of GBMs far exceed any of his colleagues globally. And he cannot understand why this is not standard of care in the brain tumor community. So Andrea's really landed in quite the little nest of really stellar folks out there. But those are some people on the directory you can see who's already at it, and know that we need to keep expanding this globally. So thank you for the opportunity. Thank you for your attention, and thank you for your brilliance. You guys are already doing this. I just want to reiterate what Margaret said and what Katrina's voiced here as well. You are already doing it. Just take that next leap, that next step of supporting people's terrain so they can become more resilient to whatever they've got, whatever they're facing.